You know, usually when we talk about like a medical diagnosis, there's this expectation of precision, right?
Absolutely. It's usually pretty binary.
Yeah, exactly. Like if a patient comes in and says they broke their arm, you get an x-ray, you see this jagged white line through the radius, and you just point at the screen and say, well, there it is.
Right. The bone is broken or it isn't. The clinical path forward is just instantly clear.
Right. But then you step into the world of pulmonary medicine and you throw a chest radiograph up on the screen, and instead of a clean break, you just see this spot.
It's just a shadow.
Yeah, a shadow. And suddenly that precision completely vanishes. I mean, we are looking at a diagnostic landscape that is just entirely murky.
It really is. It's the absolute definition of diagnostic muddy waters.
Yeah.
And, as a clinician, navigating those waters without getting lost in the weeds, or worse, sending the patient down the wrong algorithmic path,
Yeah,
it's one of the most critical clinical reasoning skills you can develop.
totally. Well, welcome to the deep dive, everyone. If you're joining us today, you are likely sitting in front of like a massive stack of pants prep materials, medical guidelines, clinical research notes, and you're just trying to make sense of pulmonology.
It can be a lot to take in.
It is a ton.
Yeah.
So our mission today is to synthesize all of those sources into a clear, actionable framework. Sitting across from me is your clinical educator, and I'll be tackling this material right alongside you as a fellow PA student. We're going to conquer these murky diagnostic waters together.
I love that. And to keep us strictly focused, we actually have 3 clear learning objectives for this deep dive.
Okay, lay 'em on me.
All right, so by the end of our time today, you will be able to, number 1, perfectly define a solitary pulmonary nodule and clinically distinguish it from a mass.
Crucial distinction.
Right. Number 2, you'll master the illness scripts to stratify malignancy risk, and that's based on both patient history and radiographic factors.
Okay, got it.
And number 3, we're going to navigate the exact diagnostic and management algorithms that the boards expect you to know inside and out.
Because we aren't just, memorizing bullet points here. We are building true clinical reasoning, like how a PA thinks, not just what a PA knows.
Exactly.
And to anchor all of this, we need a patient case. So listeners, keep this scenario in the back of your mind as we move through the material today. You have a 45-year-old female patient. She has a significant pack year history of smoking.
Classic.
Yeah, very classic. So she comes into the clinic with a persistent cough, so you order a chest radiograph. The read comes back revealing a solitary lesion located right in her upper lobe.
Okay, let's unpack this. I mean, this scenario is just bread and butter for the PNT,
Oh,
right?
absolutely. It's a textbook board scenario. But,
Sure.
Before we rush in to diagnose this patient or even consider a biopsy, we have to precisely define what we are actually looking at on her radiograph.
Because strict definitions dictate the algorithms.
Exactly. In medicine, words matter. So let's start with the textbook definition from our sources, the 30-millimeter rule. So a solitary pulmonary nodule is a single small lesion, specifically less than or equal to 30 millimeters.
Right.
And it is usually well circumscribed, and crucially, it has to be entirely surrounded by pulmonary parenchyma.
Yes, and that phrase, surrounded entirely, that is a major key for your illness script.
What does that practically mean on an image?
It means the lesion is not attached to the hilum, it's not involving the mediastinum, and it's not, sitting in a pleural effusion. It has to be this island of tissue that is completely enveloped by normal air-filled lung space.
Okay, right. Because if it's touching the chest wall or the diaphragm, the diagnostic pathway just shifts entirely.
Exactly.
Now, regarding that 30-millimeter cutoff, I was thinking about this. That is roughly the size of, a $50 coin.
Yeah, about that.
And I always look at these strict cutoffs in the textbooks and wonder about the actual clinical reality. Like, if a board question states a lesion is 31 millimeters, does the nomenclature really just flip immediately to the mass category?
It does. I mean, on the PNCs, that is a hard, high-yield line in the sand. Any lesion measuring greater than 30 millimeters is straight up considered a mass.
Wow. Okay. No gray area there.
No, and the reason the guidelines are so rigid about this is actually based on statistical survival curves and doubling times.
Oh, really?
Yeah, once a lesion crosses that 30-millimeter threshold, its malignant potential just skyrockets. The pretest probability of cancer changes entirely. So a 15 mm nodule and a 35 mm mass, they trigger entirely different sets of clinical alarm bells.
That makes a lot of sense. You know, when I first started reviewing these notes, my brain just automatically equated spot on the lung with lung cancer.
Sure, most people do.
Right. But looking at the epidemiological data in our sources, that is actually a massive cognitive trap. Because malignancy isn't even the most common etiology for a solitary pulmonary nodule.
No, it's not. What's fascinating here is that over 75% of all benign nodules turn out to be infectious granulomas.
75%. That is a phenomenal statistic to keep in mind.
It really is. And when you see the term infectious granuloma, you need to immediately think about the immune system's mechanism of action.
Like how it forms in the first place.
Exactly. A granuloma forms when macrophages fail to destroy a pathogen, right? So the immune system just simply walls it off to prevent it from spreading.
It eventually builds a cage around it.
Yeah, cellular cage.
Yeah.
And over time, that walled-off cluster of immune cells and debris, it calcifies, leaving this permanent shadow on an X-ray.
And the specific pathogens driving this are highly testable. We are talking about mycobacteria, specifically tuberculosis, and then those endemic fungi like histoplasmosis and coccidioidomycosis.
Right, the classic fungi.
And this is where the patient's social history becomes just as powerful as the X-ray itself.
Oh, 100%.
Yeah.
You were tying geography directly to etiology here. Like if the board prompt mentions a patient who recently traveled to the Ohio or Mississippi River valleys, you should immediately be suspicious of histoplasmosis.
Cave exploring, bird droppings, all that fun stuff.
You got it. And if they were working outdoors in the southwestern United States, you think coccidioidomycosis?
Now, obviously not every nodule is a walled-off fungus. The sources do list benign and malignant tumors as key etiologies too, so primary lung cancer, metastasis from another site, or carcinoid tumors.
Right, you always have to keep those on the differential.
Oh, and before we move on to risk stratification, our prep materials drop this really great piece of bonus knowledge here. If you get a question about a mass that isn't in the lung parenchyma, but rather sitting centrally in the mediastinum, the most common mediastinal tumor is a thymoma.
Yes, that is a classic nice-to-know pearl. It occasionally pops up just to test your anatomical boundaries.
Good to tuck away in the brain.
Exactly.
Yeah.
But let's bring our focus back to the lung parenchyma and our anchor patient.
Right, our 45-year-old female smoker with the upper lobe lesion.
Right. So now that we've established she actually has a nodule, our immediate job is to decide how dangerous it is. We have to stratify her risk.
And to do that, we have to build out two contrasting illness scripts, right? The high-risk nodule versus the low-risk nodule.
Exactly. Let's start with the high-risk radiographic features.
Okay, so the major red flag I saw over and over is a spiculated nodule. And when I first learned this, I just memorized the word spiculated like a shape, like a spiky sea urchin.
Which is a great visual.
But the pathophysiology here is what actually makes it dangerous, right?
Precisely. We aren't just looking at shapes, we are looking at tissue behavior. So spiculations actually represent a desmoplastic reaction.
A desmoplastic reaction.
Yeah, so those tiny spike-like extensions reaching out from the central lesion, they are literally the malignant cells invading the surrounding interstitial tissue, pulling the lung architecture inward. It's like, think of it like aggressive tree roots breaking through a concrete sidewalk. It indicates active, uncontrolled, invasive growth.
That makes the danger so much more tangible than just saying it's spiky.
It really does.
Okay, so other high-risk radiographic features include a large size, specifically greater than 2 centimeters, irregular lobulated borders, and an upper lobe location. Wait, let's actually pause on that last one. Why does an upper lobe location specifically increase the risk of malignancy?
It's a great question. And it comes down to pulmonary physiology, specifically ventilation perfusion ratios, or VQ mismatch.
Okay, taking me back to physio.
I know, right? But in an upright human, the upper lobes have relatively more ventilation compared to blood flow than the lung bases do.
Right, because blood pools at the bottom due to gravity.
Exactly. Consequently, when a patient inhales carcinogens like cigarette smoke, those toxic particulates tend to settle and concentrate in the upper lobes. The localized tissue damage and genetic mutations are just simply higher in that specific geography.
Which perfectly explains why our anchor patient's upper lobe lesion is so deeply concerning.
Exactly.
And we also need to layer patient demographics on top of those radiographic findings, right? So the high-risk patient factors are age over 40, a history of smoking, female gender, a history of emphysema, or previous asbestos exposure.
Spot on. And conversely, The decreased risk features, so your low probability illness script, they're essentially the clinical inverse.
Right.
Radiographically, we want to see well-circumscribed, perfectly smooth borders, a lesion that looks like a clean glass marble rather than, invasive tree roots.
A marble, I like that.
And we want it to be small, ideally less than 1 centimeter. And then patient factors for low risk include being under 30 years of age and having absolutely no smoking history.
Okay, but we need to address a massive pants trap hiding right in the middle of these radiographic risk factors, and it revolves entirely around calcification.
Oh, yes. This is where students often get fooled. Let's actually turn this into an interactive pause to simulate some active recall for everyone listening.
Oh, I love it. Put me on the spot.
All right, listeners, I want you to picture a board question. The prompt describes a solitary pulmonary nodule and explicitly mentions the presence of calcification. What specific type or pattern of calcification points to a benign lesion, and what pattern screams malignancy? Take a second to think through the mechanism.
This is a tricky one.
All right, here is the clinical reality. Asymmetric calcification is a high-risk feature for malignancy. However, dense, diffuse calcification is a low-risk feature, strongly indicating a benign process.
This is where I always got tripped up early in my studies. You see the word calcification on a test, your brain just panics, and you immediately associate any abnormality with cancer.
It's a very natural reflex.
But understanding the mechanism changes everything, because dense diffuse calcification means the entire lesion has just slowly solidified over years. It is the hallmark of an old, healed granuloma. Like, it's essentially a pulmonary scar.
Exactly. It's static. But asymmetric off-center calcification tells a very different story. It often represents a rapidly growing malignant tumor that has either engulfed an old adjacent calcified granuloma as it expanded, or it represents dystrophic calcification occurring in the necrotic, dying center of a tumor that has basically outgrown its own blood supply.
Wow, okay. So it's a chaotic pattern versus a stable pattern.
Exactly.
So let's do a case check-in. Our 45-year-old female smoker has an upper lobe lesion.
Right, so she is accumulating high-risk points at an alarming rate. Age over 40, female, active smoker, and an upper lobe location.
Yeah, that's 4 strikes right there.
And because she fits the high-risk illness script so perfectly, we cannot just guess. We require a definitive diagnostic workup. The guidelines demand the right imaging executed in the exact right order.
Okay, so looking at the clinical algorithms in our prep materials, the chest radiograph is almost always the initial test.
Yeah.
That's usually where the nodule is found, incidentally, right? Like a patient comes in for a pre-op clearance, they get a routine x-ray, and suddenly, boom, there's a shadow.
Exactly. But an x-ray is merely a 2D shadow. You really cannot evaluate spiculation or asymmetric calcification patterns on a standard radiograph.
Right, it's just not detailed enough.
And you certainly cannot make life-altering surgical decisions based on it. We need a 3-dimensional look, which means we need a CT scan.
And this is where I really wrestled with the guidelines.
Oh, yeah?
Yeah, because our sources explicitly state that a CT of the chest without contrast is the preferred initial imaging modality to determine the likelihood of malignancy for an incidentally found nodule.
Right, non-contrast.
But every instinct I have tells me to use intravenous contrast to light up the vascular supply. Like, if I suspect a growing, hungry tumor, why am I explicitly instructed to avoid contrast on the initial CT?
It's a totally understandable instinct, I promise you. But it ignores the physics of the imaging itself.
How so?
Think back to our calcification trap we just talked about.
Well,
the pattern of calcium dense and diffuse versus asymmetric is arguably our most vital non-invasive clue, right? Well, on a CT scan, radiodensity is measured in Hounsfield units. Intravenous iodine contrast appears extremely bright white on the scan. Do you know what else appears bright white?
Calcium.
Precisely. If you flood the pulmonary vasculature with contrast, it can completely obscure the intrinsic calcification pattern of the nodule itself.
Oh, wow. I didn't even think about that.
Yeah, the contrast bleed makes it practically impossible to differentiate an old granularity from an active tumor. So for the absolute baseline characterization of the nodule's raw architecture, its exact borders and its calcium distribution, a non-contrast CT provides the most unadulterated anatomical data.
Ah, okay. So we need the raw structural bus line before we even look at the vascularity.
Exactly.
That makes perfect sense. Now, the algorithms also mention utilizing a PT scan. How does that differ from the CT we just ordered?
Well, if we connect this to the bigger picture, a CT scan provides your structural data. A PT scan, on the other hand, provides metabolic characterization. We inject the patient with FDG, which is basically a radioactive glucose analog.
Right, and because malignant cells have unregulated glycolysis, the Warburg effect, if I remember my biochem, they are highly metabolically active compared to normal tissue.
Exactly. They are greedy for glucose, so they trap that FDG radiotracer. So, on a PT scan, a malignant tumor will demonstrate stark hypermetabolic uptake. It quite literally lights up on the scan, allowing us to differentiate highly active cancer cells from dormant scar tissue.
Okay, so structural versus functional imaging. I get it. So we have the images, we have accurately assessed the patient's risk. Now we reach the critical endpoint for the board exam. Management. Like, what is the actual clinical intervention we do?
Right, and the management algorithm is dictated entirely by the pre-test probability of malignancy we just established.
The illness scripts from earlier?
Yes. The guidelines break this down into 3 strict categories: low probability, intermediate probability, and high probability.
Let's walk through them. Starting with low probability. This is our smooth glass marble, right? Like a 25-year-old non-smoker with a densely calcified 8-millimeter nodule. The algorithm says the correct move here is active surveillance.
Yes. We absolutely do not want to subject a healthy, asymptomatic young person to an invasive thoracic biopsy. So, following the Fleischner Society guidelines, we monitor the patient with serial CT scans over specific time intervals to ensure the nodule isn't doubling in size or changing its border characteristics.
Just watch and wait. Okay, what if the nodule falls into the intermediate probability category? So it isn't definitively benign scar tissue, but it lacks the overwhelming red flags of obvious cancer.
This is the tricky middle ground.
Right. The guidelines dictate we need tissue, we need a biopsy, but the exact method of biopsy depends entirely on the geographical location of the nodule within the lung.
Yes, and this distinction is incredibly high yield for the pantas. So let's do our second interactive pause right here.
Bring it on.
Listeners, imagine our patient has an intermediate probability nodule. The CT scan reveals the nodule is located on the extreme outer periphery of the lung, basically sitting right up against the chest wall. Do we biopsy this using bronchoscopy, or do we use transthoracic needle aspiration? Take a moment.
Right. Peripheral lesion.
The board-correct answer for peripheral lesion is transthoracic needle aspiration.
You know, I rely on a lung geography analogy to keep this straight under pressure.
Oh, let's hear it.
So think of the pulmonary system like a major city, right? A bronchoscopy goes down the trachea and navigates through the major bronchi. It is utilizing the airway highways.
I like that. Airway highways.
Yeah, and that tool is fantastic if you need to reach the center of the lung, the downtown central area. If the prompt describes a central lesion, bronchoscopy with biopsy is your answer.
But the airway highways eventually narrow and terminate.
Exactly. If the lesion is out in the periphery, the deep suburbs of the lung parenchyma, the bronchoscope simply cannot navigate out that far. It's too narrow. So you have to bypass the airway highways entirely and drive a needle straight through the chest wall from the outside. That is your transthoracic needle aspiration. Downtown gets the bronchoscope, the suburbs get the needle.
That is a perfect anatomical visualization. I'm going to steal that from my lectures.
Go for it.
Finally, we arrive at the high probability category.
High probability means we bypass the less invasive diagnostic steps entirely, right? The recommended management is resection with biopsy. We take the lesion out and test it simultaneously.
Which brings us back to our anchor patient to close the loop on her clinical journey. She is a 45-year-old female smoker.
Right.
She has an upper lobe lesion that demonstrated spiculated borders on her initial non-contrast CT.
Okay, so her clinical risk factors combined with her radiographic data place her squarely in the high probability category.
Unquestionably.
Therefore, her definitive board-correct management step is surgical resection with biopsy. We are not watching and waiting, and we are not just aspirating a few cells. We are removing the threat.
Exactly. You correctly defined the lesion, built an accurate illness script to stratify her risk, ordered the mechanistically appropriate imaging, and executed the definitive management plan.
Boom.
That is the essence of solid clinical reasoning.
Man, that feels good to put it all together. So how do we distill all of this pathophysiology and algorithmic logic down for test day? It is time for our rapid-fire key takeaway summary. Let's lock in the absolute must-knows from today's sources.
Let's do it.
All right, first, the strict 30-millimeter cutoff. 30 millimeters or less is a nodule. Anything measuring greater is a mass with a drastically higher malignant potential.
Second, do not assume cancer immediately. Infectious granulomas driven by mycobacteria and endemic fungi are the most common benign etiology.
Third, respect the calcification trap. Dense and diffuse calcification is a stable, benign scar. Asymmetric calcification indicates chaotic, suspicious growth.
Fourth, a CT of the chest without contrast is your preferred initial imaging to evaluate the raw architecture of an incidental X-ray finding.
And finally, know your lung geography for biopsies. Use the airway highways of a bronchoscopy for central lesions, and use transthoracic needle aspiration for peripheral lesions.
That is a highly effective synthesis. You nailed it.
Thank you.
Now, let's put that clinical reasoning to the test with 3 board-style multiple-choice questions. I will read the clinical prompt, give you a moment to process, and then we will break down the exact rationale behind the correct answer.
I am ready. Let's hit question 1.
All right. A 28-year-old male with no history of smoking presents to the clinic for a routine pre-employment physical. An incidental lesion measuring 34 millimeters is identified in the right lower lobe on a standard chest radiograph. By strict definition, what is this lesion called, and what is its primary clinical significance?
Okay, so the PANTS is clearly trying to distract us with the patient's low-risk demographics here.
Oh, for sure.
Young, non-smoker, lower lobe. But the measurement is the absolute key. 34 millimeters is strictly greater than 30. Therefore, the answer is a mass. And its clinical significance is that it carries a high malignant potential, which entirely supersedes his low-risk demographics. The physical size alone dictates the terminology and the heightened urgency.
Superb trap avoidance. You didn't fall for the age distraction.
Not today.
All right, question 2. Which of the following radiographic findings specifically decreases the pretest probability of malignancy in a newly discovered solitary pulmonary nodule? Option A, spiculated borders. Option B, upper lobe location. Option C, dense diffuse calcification. Or option D, asymmetric calcification.
Okay, so we're scanning the options for the benign illness script.
Yep.
Option A, spiculated borders that represents the desmoplastic reaction and tissue invasion. High risk.
Yep.
Option B, upper lobe location. That is where inhaled carcinogens concentrate due to VQ mismatch. High risk.
Correct.
Option D, asymmetric calcification that indicates chaotic dystrophic calcification often seen in necrosis. High risk.
Right.
Therefore, the correct answer is C, dense diffuse calcification. That is the hallmark presentation of an old, fully healed granulomatous process.
Flawless process of elimination. All right, our final question. Question 3. A 55-year-old patient is found to have an intermediate probability solitary pulmonary nodule. Non-contrast CT imaging reveals the 18-millimeter nodule is located centrally within the lung parenchyma near the mainstem bronchus. What is the most appropriate next step in the management algorithm?
Okay, the prompt establishes 2 vital facts here. It's intermediate probability, meaning we absolutely require a tissue biopsy.
Right.
And it is located centrally. So because it is located in the central downtown area of the lung anatomy, we can utilize the major airways to reach it. The answer is bronchoscopy with biopsy.
Spot on. Listeners, if you can organically reason your way through those clinical scenarios without just guessing, your foundational understanding of this topic is incredibly strong.
We took a murky, poorly defined shadow on a 2D radiograph, applied pathophysiology and strict definitions, and brought absolute clinical precision back into the picture.
We really did. But before we wrap up today, this raises an important question, a provocative thought that extends well beyond the rigid algorithms of our prep books.
Okay, what is it?
Think deeply about the required management for a low-probability nodule.
Right.
Active surveillance.
Right. Just watching.
Exactly. Medically, statistically, and radiographically, it is the absolute correct, evidence-based move to simply watch and wait. But I want you to imagine the reality of being that patient.
Oh, wow. Yeah.
Imagine sitting in an exam room being told you have a spot on your lung, but that the medical team is not going to do anything about it today. You were just supposed to go home, try to live your life normally, and return in 6 months to see if it grew.
That is an incredibly heavy perspective. I mean, the sheer psychological anxiety of walking around every single day with that knowledge. It must be suffocating.
It is an immense burden. And as a future PA, you are never just managing a Hounsfield unit on a CT scan. You are managing the human being absorbing that information.
Yeah, the whole person.
Exactly. Your ability to clearly communicate the why behind active surveillance, to genuinely reassure them with the physiological data we discussed today, explaining exactly why dense diffuse calcification means they are safe. The communication is arguably more vital than simply memorizing the 30-millimeter rule.
That's so true.
How you treat the patient's mind while you monitor their lung is the true art of practicing medicine.
That is a phenomenal grounding thought to end our review on. You have to treat the whole person, not just the algorithm.
Absolutely.
Well, thank you all for diving into these materials with us today. Keep trusting your training, keep refining those illness scripts, and keep crushing your PANCS prep. You've got this. We will see you on the next deep dive.